You know, cholesterol is a word that echoes through our health consciousness. We hear it, we might even track it, always with an eye on our heart.
Hmm.
But what if I told you that this familiar fat, these lipids, aren't just sending signals to your ticker?
Right.
What if they're also deeply, surprisingly, and often overlooked, involved in the clarity of your thoughts, the sharpness of your memory, and even the landscape of your mood?
It's true. For too long, we've treated the body as a collection of separate departments.
Yeah.
You know, the heart, the brain, the mood.
Silos.
But as we unpack today, these aren't isolated islands. They're interconnected continents. And the health of one profoundly influences the others.
Absolutely. This isn't just another discussion about diet and heart health, folks.
No, definitely not.
This deep dive is going to propel us beyond the well-trodden paths of cardiovascular care to illuminate the truly intricate connections between your lipid profile, that's your cholesterol, and other fats, your emotional well-being, and your cognitive performance.
And we're drawing insights from a stack of fascinating sources today, including the latest clinical guidelines and some groundbreaking research from powerhouse institutions like Columbia University.
Right, and all cross-referenced with robust data from the National Health and Nutrition Examination Survey, or NAEs as it's usually called.
Our mission today, for you, our curious listener, is to cut through the often dense and, let's be honest, technical complexity.
Yeah, it can be a lot.
We want to extract the most important nuggets of knowledge, giving you a real shortcut to being well-informed. You'll gain a fresh perspective on the far-reaching impact of lipids on your entire system, with a very special focus on the mind.
Get ready for some genuine aha moments and a fresh perspective on what it truly means to be holistically healthy. So to build a strong foundation for this journey into the mind, let's first ensure we're all on the same page about what we mean when we talk about lipid health, or perhaps more accurately, lipid imbalance.
Good starting point.
Okay, let's unpack this. We're kicking things off with the basics, but it's crucial to understand that dyslipidemia isn't just one straightforward condition.
No, not at all.
It's actually a whole family of related conditions, some inherited and some acquired during our lives.
That's a critical distinction. At its most fundamental level, dyslipidemia refers to an abnormal metabolic status. In simpler terms, it means there are persistently unhealthy concentrations of lipids fats circulating in your bloodstream.
So, too much or too little of certain fats.
Exactly. Think of it less as a single problem and more like a finely tuned orchestra where certain instruments are playing too loudly or perhaps not loudly enough, throwing the whole system out of balance.
And the global impact of this unbalanced orchestra is absolutely staggering. Our sources highlight it as a truly significant public health problem, considered a leading cause of mortality worldwide.
The numbers are quite sobering.
We're talking about an estimated 17 million deaths every year, largely attributed to cardiovascular disease, heart attacks, and strokes, which are often direct, devastating complications of untreated dyslipidemia. It's a silent killer that casts an enormous shadow across global health.
The silent nature is perhaps its most insidious characteristic. Dyslipidemia is generally asymptomatic, meaning you typically don't feel it. There are no obvious warning signs waving a red flag.
Nothing hurts, necessarily.
Right. You often don't know you have it until complications arise. These can range from ischemic heart disease, where blood flow to your heart is restricted, to a stroke, which impacts your brain. This lack of early warning signs makes regular screening and a deep understanding of its mechanisms incredibly important.
So if it's so silent, how do we even begin to detect it? It all comes down to understanding the key players, the actual lipids that make up your lipid profile.
Exactly.
You've got a few main characters we need to get acquainted with, each with a distinct role.
The first is total cholesterol, or TC. This is simply a general measure of all the cholesterol in your blood. It's a good starting point, like taking a quick glance at the overall picture, but the real insights come from breaking it down into its components.
Right. And then you have the famous, or maybe infamous, low-density lipoprotein cholesterol, which we call LDLC. This is the one that has, unfortunately, but quite accurately, earned the nickname bad cholesterol.
The bad guy. Its primary role is to carry cholesterol from the liver to cells throughout your body. And every cell does need cholesterol for building membranes and hormones, so LDL isn't inherently bad.
Okay, that's important. It has a job.
It does. The problem arises when levels are too high. When there's an excess, these LDL particles can contribute to the formation of fatty plaques within your arteries, a process known as atherosclerosis.
That plaque buildup.
Precisely. Imagine the smooth, clear pipes of your plumbing system slowly getting coated with sticky residue and rust inside. progressively narrowing the passageway. This reduces blood flow, stiffens the arteries, and significantly increases the risk of blockages, which can lead to life-threatening events like heart attacks or strokes.
And thankfully, on the flip side of that coin, we have high-density lipoprotein cholesterol, or HDLC. This is the unsung hero that earns its moniker as the good cholesterol.
The good guy.
It's like the cleanup crew for your arteries, right?
Exactly. HDLC acts as a scavenger. Its crucial role is to help remove excess cholesterol from your arteries and transport it back to the liver for excretion.
Taking out the trash, basically.
You could put it that way. So lower levels of HDL mean less of this vital cleanup crew is available, accelerating plaque formation and increasing the risk of those dangerous blockages. It's an essential part of maintaining arterial health.
And finally, we have triglycerides, or TG. These often get less airtime than cholesterol, but they're just as important for overall metabolic health.
Absolutely. Triglycerides are essentially the body's stored form of energy. They're stored in your fat cells and released as fuel when your body needs it. They're an essential energy source.
But like LDL.
But like LDL, high triglyceride levels can also contribute to plaque formation and inflammation in the arteries. And in very high concentrations, typically at or above 500 milligrams per deciliter, they can trigger a painful and dangerous condition called pancreatitis.
Oh.
So, maintaining a balanced level across all these lipids is absolutely key to your health.
Now, when we discuss dyslipidemia, it's not a monolith. It manifests in different forms, primary and secondary. Understanding this distinction is really important, isn't it? As it guides how we approach prevention and treatment for each individual.
That's a fundamental distinction for a reason. Primary dyslipidemia is largely inherited or genetic. It's caused by specific genetic mutations that directly affect how your body metabolizes lipids.
So it runs in families.
It often does. For instance, familial hypercholesterolemia is a relatively common genetic condition affecting about 1 in 250 to 1 in 500 people in many populations, though it can be much higher in certain ethnic groups, like 1 in 67.
Wow, that's quite common.
It is. Other examples include familial hypertriglyceridemia and familial combined hyperlipidemia. These conditions are essentially coded into your DNA, impacting how your body produces, processes, or clears fats.
So these are essentially issues at the genetic level, predisposing individuals to unhealthy lipid levels from the get-go.
Precisely. These genetic defects can involve problems in the synthesis, transport, or degradation of lipoproteins. For example, in familial hypercholesterolemia, there are mutations in the LDL receptor gene.
The receptor we mentioned earlier.
Yes, the gene that makes the receptor. So the liver can't efficiently remove LDL cholesterol from the bloodstream, leading to very high levels from a young age. This highlights why early screening can be so vital, particularly if there's a family history of heart disease at an unusually young age, signaling a potential genetic predisposition.
And then there's secondary dyslipidemia, which sounds like it's more about the choices we make and the conditions that develop during our lives.
Exactly. Secondary dyslipidemia is acquired, meaning it's caused by lifestyle factors or other underlying medical conditions that alter lipid levels.
The good news there.
The encouraging news here is that it's often reversible, or at least highly modifiable, by addressing the root cause. Common risk factors include a sedentary lifestyle, unhealthy nutrition, think diets, consistently high and saturated in trans fats, or excessive sugar.
The usual suspects.
Right. Obesity and chronic conditions like diabetes or hypothyroidism, even liver disease, excessive alcohol consumption, smoking, and the use of certain medications such as corticosteroids, beta blockers, oral contraceptives, or antiretroviral agents can significantly contribute to secondary dyslipidemia.
So it's a rather long list of factors that can nudge our lipid profile out of its healthy balance. How do these diverse factors actually cause the changes we see in our blood work? Like, what's the mechanism?
Well, the mechanisms are quite varied and complex. For instance, obesity significantly increases the liver's production of very low-density lipoprotein, or VLDL, a precursor to LDL,
Okay.
while also impairing the body's ability to clear chylomicrons, those fat packages from our diet, from the bloodstream. This can lead to elevated triglycerides and lower HDL levels.
Or double whammy.
Diabetes, particularly type 2, is often linked to insulin resistance, which impairs the breakdown of triglycerides. On the other hand, hypothyroidism can decrease the expression of LDL receptors on liver cells, making it harder for the body to efficiently remove LDL cholesterol from the blood.
Fascinating. Different routes to the same problem.
These are complex biological interactions, yes, but the bottom line is that many common health issues and daily lifestyle choices have a direct and profound impact on our lipid health.
So if these issues are so prevalent and often silent, how do we even begin to detect and then manage them effectively, especially when the goal is to protect our heart, arguably one of the most vital organs?
What's truly fascinating here is how far we've come in understanding the nuances of dyslipidemia management. We've evolved from broad, generalized recommendations to highly individualized care plans.
Tailored medicine.
Exactly. It's a testament to decades of rigorous research and clinical practice.
That research definitely seems to emphasize early identification as a critical first step. It just makes intuitive sense, doesn't it?
Absolutely.
The sooner you know there's an issue, the sooner you can take action to mitigate the long-term impact of unhealthy cholesterol levels and prevent or at least significantly delay serious complications like heart attacks or strokes.
Couldn't agree more. However, the recommendations for when and how often to screen for dyslipidemia can vary a bit between different professional organizations. It's not always perfectly aligned.
How interesting. Like who says what?
Well, for instance, the National Heart, Lung, and Blood Institute back in 2011 suggested universal screening for kids between 9 and 11, and again between 17 and 21. Others, like the American Academy of Pediatrics, or AAP, focus more on selective screening for younger people with risk factors.
Like family history or obesity.
Exactly. Family history of dyslipidemia or early cardiovascular disease, obesity, diabetes, hypertension, smoking, those sorts of things. But for those over 21, the AAP leans towards universal testing. The U.S. Preventive Services Task Force has its own criteria, too, recommending screening for men 35 and older and women 45 and older, or earlier if they have risk factors.
So the clear trend is towards earlier and more individualized screening, adapting to a person's risk profile, even if the exact ages differ slightly.
Precisely. For adults, organizations like the American Heart Association and American College of Cardiology suggest routine lipid screening every 4 to 6 years for patients between 40 and 75, with more frequent assessments for those at higher risk. The consistency across these various guidelines is the emphasis on regular screening, tailored to individual circumstances, because, as we said, this is often a silent condition.
And the gold standard for diagnosing these lipid levels is a test many of us have likely experienced, the fasting lipid panel.
Yes, this test requires you to fast for at least 12 hours before your blood sample is collected. No breakfast that morning.
Right.
It measures your fasting total cholesterol, triglycerides, and HDL-C. The bad cholesterol, LDL-C, can then be calculated using what's called the Friedewald
A
equation.
mathematical formula.
Essentially, yes. However, if your triglyceride levels are very high, specifically above 400 milli-GDL, a direct assay for LDL-C is preferred because the calculation can be less accurate in those cases.
Got it. So once we have these numbers from the lab, what's considered normal or healthy, it can be a bit confusing to interpret those results on your own.
That's a common question. Think of it this way. For total cholesterol, a desirable level is generally below 200 milli-GDL. Anything 240 milli-GDL or above is considered high and certainly raises a red flag for concern.
Okay, under 200 is good for total.
For LDL-C, our bad cholesterol, optimal, is typically below 100 milli-GDL, with anything 190 milli-GDL or above considered very high and requiring immediate attention.
And what about the good cholesterol HDL-C? What should we aim for there?
For HDL-C, a level below 40 milli-GDL for men or below 50 milli-GDL for women is considered low, which means you have less of that crucial cleanup crew. A high, and therefore desirable level, is 60 milli-GDL or greater.
So higher is better for HDL.
Higher is better, yes. Finally, for triglycerides, normal is less than 150 milli-GDL, and anything at or above 500 milli-GDL is considered very high and increases the risk for pancreatitis, as we mentioned.
Right.
These are key markers your doctor looks at, and understanding the general healthy ranges helps you be an informed participant in your own health journey. And for kids, by the way, the cutoffs are different, generally lower.
Once we have a diagnosis, how do we manage dyslipidemia? It sounds like there's a powerful two-pronged approach, starting with something everyone can implement immediately.
Absolutely. The first line of defense, and indeed the foundational approach for literally all ages, is non-pharmacological management. This means endorsing a healthy lifestyle.
Lifestyle first.
Always. This is where you, the individual, have the most direct and profound control over your lipid profile.
So diet is obviously first and foremost. What does a heart-healthy diet actually look like in practice, beyond just eat your veggies?
Well, it's primarily about strategic reductions and smart inclusions. Key strategies include significantly reducing your intake of saturated and trans fats.
Where do we find those, mostly?
Saturated fats are high in red meat, full-fat dairy, coconut oil. Trans fats, thankfully less common now, were often in processed baked goods and fried foods. The American Heart Association, for example, recommends limiting saturated fat to less than 6% of your daily calories and explicitly advises avoiding trans fats entirely.
Okay, cut those down. What to emphasize instead?
I think it often translates to limiting red and processed meats, reducing sodium, and cutting back on sugar-sweetened foods and beverages. On the flip side, you want to emphasize a colorful array of fruits and vegetables, whole grains, lean poultry and fish, healthy fats from nuts, seeds, and non-tropical vegetable oils like olive oil and avocado oil.
So things like the Mediterranean diet.
Think along the lines of eating plans like the DASH diet or the Mediterranean diet. Yes, they are well proven to improve heart health and have numerous other benefits.
And beyond what's on our plate, what about getting our bodies moving?
Physical activity is absolutely vital. A sedentary lifestyle directly contributes to lower levels of HDL, our good cholesterol.
So sitting around lowers the good stuff.
It does. The general recommendation is to aim for at least 150 minutes of moderate intensity aerobic exercise per week. That could be brisk walking, swimming, or cycling.
3 times a week for 50 minutes, maybe.
Or 5 times for 30, however you break it down. Or, if you prefer, 75 minutes of vigorous intensity aerobic exercise, like running or jumping rope. Crucially, you should also include muscle-strengthening exercises at least twice a week.
Weights or resistance bands.
Exactly. This combination is powerful enough to significantly lower both unhealthy cholesterol levels and high blood pressure. It's a double win for your cardiovascular system.
I know weight management also plays a huge, often underestimated role.
It does, and it's surprisingly impactful. Being overweight or obese directly increases bad cholesterol and lowers good cholesterol. But here's the remarkable thing. Even a modest weight loss, as little as 5% to 10% of your body weight, can dramatically improve your cholesterol numbers and other heart disease risk factors.
Really, just 5–10%? That seems achievable.
It's about cumulative benefits, where every step towards a healthier weight contributes to a healthier lipid profile. It makes a real difference.
And of course, the obvious one, which we know has countless health benefits, smoking cessation.
Indeed, smoking and vaping are highly detrimental. They actively lower HDL cholesterol and greatly exacerbate the risk of coronary heart disease, especially when combined with unhealthy cholesterol levels.
A bad combination.
A very bad combination. The good news is that quitting offers rapid benefits. It significantly lowers triglycerides and increases HDL, providing immediate and lasting improvements to your cardiovascular health. It's one of the most impactful changes you can make.
So we start with these foundational lifestyle changes. But what happens if those aren't enough, or if someone's cholesterol levels are dangerously high from the outset due to genetics or severe lifestyle factors?
That's when we turn to pharmacological therapy. And the cornerstone here, for many patients, is a class of medications known as statins.
The famous statins.
Yes. These medications work by targeting an enzyme called HMG-CoA reductase. Think of this enzyme as a master switch for your body's own cholesterol factory in the liver.
Okay.
By inhibiting it, statins effectively slow down that factory. This action then triggers an increase in LDL receptors on the surface of liver cells, which are like little sponges.
Sponges for LDL.
Right. These sponges then clear more LDL cholesterol from the blood, effectively lowering its circulating levels.
And statin therapy isn't a one-size-fits-all approach, is it? It's highly individualized, depending on your specific risk profile.
Exactly. Treatment is intensity-based, tailored to a patient's unique cardiovascular risk. For individuals with existing atherosclerotic cardiovascular disease, meaning they've already had a heart attack or ischemic stroke,
High risk.
very high risk, or those aged 40–75 with very high LDL levels, say above 190, or with diabetes, high-intensity statin therapy is prescribed. This therapy aims for a significant reduction of 50% or more in LDL cholesterol.
A big drop.
A big drop. For others, such as patients age 40–75 with moderately elevated LDL and an intermediate 10-year risk of ASCVD, moderate intensity statins might be prescribed, aiming for a 30–49% LDL reduction. The goal is always to achieve specific target LDL-C levels, which vary based on your risk.
So there are specific LDL goals, like aiming for below 70 mg/dL for very high-risk individuals, or below 100 mg/dL for high-risk patients. These targets are crucial for guiding treatment intensity.
Precisely. However, it's also important to acknowledge that statins, while incredibly effective, do have potential side effects.
The muscle aches people talk about?
That's the most common one, yes. These can include muscle pain, inflammation or breakdown known as myalgia, myositis, myopathy, or in severe cases, rhabdomyolysis. There's also a small but documented risk of hepatic failure, so liver problems and new onset diabetes. These are all monitored closely by healthcare providers.
And what if maximal statin therapy still isn't enough to hit those critical targets, or if a patient simply can't tolerate statins due to side effects? Are there other tools in the pharmacological arsenal?
Thankfully, yes, and our toolkit has significantly expanded, especially in recent years. Often used in conjunction with statins or as alternatives, we have several options. Ezetimibe, for example, works by inhibiting cholesterol absorption in the gut.
Different mechanism entirely.
Completely different. When added to statins, it can lower LDL by an additional 25%, providing a powerful synergistic effect. Then we have a newer, exciting class of drugs, PCSK9 inhibitors.
Those sound high-tech.
They are. These are cutting-edge genetic therapies, either monoclonal antibodies or RNAi drugs. They work by regulating the number of LDL receptors on liver cells, essentially preventing the body from destroying these crucial cholesterol-clearing receptors. This leads to a dramatic decrease in LDL levels, often much more than statins alone.
That's a huge advance, particularly for people who struggle with statin side effects or for whom statins simply aren't enough.
Indeed. For instance, inclisiran, one of these RNAi drugs, works by stopping PCSK9 production entirely with just twice-yearly dosing,
Twice a year.
twice-a-year injections. It offers remarkable convenience and efficacy, especially for statin-intolerant patients. We also have icosapent ethyl, a specialized omega-3 fatty acid preparation, which reduces cardiovascular risk in patients with elevated triglycerides when added to maximal statin therapy.
So targeting triglycerides specifically too.
In that high-risk group, yes. And bempedoic acid is another oral option for statin-intolerant patients, often combined with ezetimibe. It works by inhibiting an enzyme called ATP citrate lyase, thereby lowering liver cholesterol production, another pathway.
So we have a growing and increasingly sophisticated toolkit. What about some of the older medications? Are they still in play, like niacin or fibrates?
Yes, there are other agents, though they tend to have less direct impact on major cardiovascular events like heart attack or stroke, or come with more significant side effect profiles. Fibrates are primarily used for very high triglyceride levels, typically over 500 milli-GDL, to prevent pancreatitis.
Not specific risks.
That specific risk. However, combining them with statins can increase the risk of muscle problems, so it requires careful monitoring. Bile acid sequestrants like cholestyramine and niacin, which increases HDL and reduces VLDL, are also options. But niacin in particular has a significant side effect profile. Flushing is common that often limits its use to specific cases.
With all these different medications and tailored approaches, how often do patients need to be monitored to ensure treatment is working effectively and safely?
Regular monitoring is absolutely essential. Lipid profiles should typically be checked anywhere from 4 to 12 weeks after starting therapy to assess the initial response and ensure compliance.
See if it's working.
Exactly. After that, testing intervals can extend to every 3 to 12 months, depending on the patient's individual cardiovascular risk and how well they're responding to treatment. Additionally, liver function tests and creatinine kinase, or CK, levels that's related to muscle also need regular monitoring, as these can be indicators of potential side effects from certain medications, particularly statins. It's a dynamic process of adjustment and vigilance.
Here's where it gets really interesting. I mean, the history of this is just fascinating. From centuries of debate and skepticism, we moved into an era where we finally understood the fundamental science and had the tools to make a real life-saving difference thanks to the advent of statins.
It's quite a story. If we connect this to the bigger picture, the journey of cholesterol research highlights the critical role of robust clinical trial methodology in overturning long-held beliefs and establishing evidence-based medicine. It's a powerful narrative about scientific perseverance, often against significant odds.
And what a journey it's been. The earliest whispers of this connection, the very first inklings, date back to 1847, when a scientist named Vogel first demonstrated the presence of cholesterol within arterial plaques.
Way back then.
He basically, without fully realizing it, set the stage for all future inquiry. But the real groundbreaking discovery, the one that truly ignited the field and sparked a century of debate, came in 1913.
That's when Aniszko, working in St. Petersburg, conducted an experiment that would resonate through medical history. He showed that feeding rabbits cholesterol caused atherosclerosis, those fatty plaques in the arteries.
The rabbit study.
The famous rabbit study. This finding was quickly corroborated by C.H. Bailey, and around the same time, Backmeister and Haynes independently linked elevated blood cholesterol to a range of chronic diseases like diabetes and kidney disease. So early on, there was a strong signal, a clear direction.
But then, almost immediately, the controversy ignited and deep skepticism took hold. Why did scientists start doubting such seemingly clear initial findings? What went wrong?
It was primarily due to the difficulty pathologists had reproducing Anichkow's findings in other commonly used research animals, like rats and dogs.
They didn't react the same way.
Not at all. Rabbits are unique in their metabolism. They respond to dietary cholesterol very differently than many other species, including humans. This species-specific response led to significant doubt. A prominent review in JAMA in 1935 by Leary summarized this growing skepticism, arguing that rabbits were unsuitable research animals and that the arterial lesions observed were simply due to perverted diets.
Blaming the diet.
And crucially, there was also a widespread but mistaken belief at the time that the human body couldn't synthesize cholesterol itself. If humans couldn't make it, then dietary cholesterol seemed less relevant to internal disease. This fundamental misunderstanding, combined with species differences, severely muddied the waters and effectively stalled progress for decades.
Wow, so a combination of misinterpretations and biological nuances really cast a long shadow over the cholesterol hypothesis. It sounds like a scientific whodunit where the prime suspect kept changing.
It truly became one of the major controversies in modern medical history. It wasn't until after World War II that new interest in the cholesterol and diet fat hypothesis began to rise among clinicians, spurred by crucial biochemical revelations that finally provided the missing pieces of the puzzle.
And this is where Konrad Bloch and Fyodor Linin stepped in during the 1940s, ultimately winning a Nobel Prize for their work. Their findings were pivotal, weren't they?
Their research was absolutely foundational. They definitively revealed the intricate mechanism of cholesterol and fatty acid synthesis and regulation within the human body.
So proving we do make it.
Exactly. This groundbreaking work proved, once and for all, that the human body does indeed synthesize cholesterol. This discovery provided the essential biochemical understanding that was previously missing, finally putting to rest Leary's earlier contention. Following this, in 1946, physician William Dock wrote an influential editorial in JAMA, which compellingly connected the familial incidence of coronary disease to inherited peculiarities of cholesterol metabolism and dietary habits. The pieces of the puzzle were slowly but surely coming together.
Even with these biochemical breakthroughs, we then entered an era of often disappointing clinical trials, what many remember as the diet heart. End of an era, period. It seems like the journey was still fraught with challenges.
Indeed. From the 1940s through the 1970s, early dietary clinical trials, while showing some promise in reducing coronary heart disease relapses, often failed to demonstrate significant reductions in total mortality.
People weren't living longer overall.
Right. And that was a critical endpoint. The lack of a clear overall survival benefit fueled skepticism. This reached a peak with Mann's influential article in the New England Journal of Medicine in 1977.
The famously titled Diet Heart, End of an Era. That sounds like a pretty definitive dismissal.
It was. Mann's article, based on a meta-analysis of existing data, largely ridiculed cholesterol-lowering diets as futile and even provocatively suggested they might increase cancer risk.
Wow.
This highly influential piece, coming from such a respected journal, solidified a prevailing sense that cholesterol lowering was a dead end. Simultaneously, early drug trials from the 1950s to the 1970s, using hormones like estrogen and dextrothyroxine, also yielded mixed or negative results, with some even showing an increase in mortality. It was a really discouraging time for those who believed in the cholesterol hypothesis.
And then came the large-scale trials, like the Coronary Drug Project, or CDP, from 1965 to 1975. This was a landmark effort in terms of methodology, wasn't it?
It was. The CDP was a massive nationwide trial in the U.S., meticulously evaluating several drugs, including clofibrit and niacin. While groundbreaking in its sheer scale and methodological rigor, it ultimately delivered a sobering message. It found no significant effect on all-cause mortality for clofibrit or niacin.
Still no overall survival benefits.
Still nothing. Even more troubling, some regimens, particularly estrogen and dextrothyroxine, had to be discontinued due to increased mortality. This was a major setback and deepened the pervasive skepticism within the medical community.
And the WHO clofibrit trial really drove that skepticism home, didn't it? It sounds like it almost dealt a final blow to the cholesterol theory.
It absolutely did. This large primary prevention trial, conducted from 1965 to 1978, involved healthy men with high cholesterol. It found a 20% reduction in ischemic heart disease events, but this benefit was largely confined to non-fatal heart attacks.
Okay, so fewer non-fatal events.
The truly controversial finding was a statistically significant increase in all-cause mortality in the clofibrit group. mostly from non-vascular causes like neoplasms, so cancers.
Oh my goodness, more deaths overall.
Yes, this paradoxical and deeply unsettling finding profoundly impacted scientific opinion and famously converted Professor Oliver, one of the trial's lead investigators, into a leading critic of cholesterol lowering. It appeared that the cure might be worse than the disease.
So after all that, it really looked like the cholesterol hypothesis might be dead in the water, a scientific dead end. But then, almost out of nowhere, a new hero emerged, one that would completely transform the landscape. Statins.
This is truly the turning point, a pivotal moment in medical history. In the 1970s, a brilliant Japanese biochemist named Akira Endo tirelessly searched for inhibitors of HMG-CoA reductase, that master switch enzyme we mentioned earlier.
Right, the liver factory switch.
He eventually isolated mevastatin, or ML236B, from a species of fungi. His work paved the way, and shortly thereafter, the pharmaceutical company Merck discovered a similar compound, mevanolin, which became lovastatin. This marked the birth of a revolutionary class of drugs.
And then, the science caught up in an even more profound way with the discovery of the LDL receptor, finally explaining how these new drugs actually worked.
Yes. In 1985, Joseph Goldstein and Michael Brown won the Nobel Prize for discovering the LDL receptor. This provided a fundamental, elegant mechanism. By inhibiting HMG-CoA reductase, which is precisely what statins do, you essentially tell the liver to make more LDL receptors.
More sponges.
More sponges. More receptors mean the liver can efficiently clear more LDL, the bad cholesterol, from the blood. This biochemical understanding solidified the rational and undeniable basis for statin therapy.
But even with this scientific triumph, statins faced an early, terrifying challenge, what you referred to as the muscle problem.
That's right. Initial clinical use of mevanolin, lovastatin, particularly when combined with other lipid-lowering drugs like gemfibrozil, revealed cases of rhabdomyolysis, a severe and potentially fatal muscle breakdown.
Rhabdo, that sounds serious.
It is very serious. This was a major concern, causing Merck to temporarily halt development, highlighting the paramount importance of safety in drug development. It was a stark reminder that even revolutionary drugs have risks that must be carefully addressed and understood.
However, the definitive, undeniable proof of statins' benefits came with a series of landmark clinical trials in the late 1980s and 1990s that would forever change medicine.
These trials were truly transformative, silencing the skeptics once and for all. The Scandinavian simvastatin survival study, known as 4S, conducted from 1988 to 1994, was the first large trial to unequivocally demonstrate a highly significant 30% reduction in all-cause mortality.
Finally, the overall survival benefit.
Finally, and a 30% reduction in major coronary heart disease events with simvastatin, specifically in patients with existing coronary heart disease. This brought immediate relief among believers, finally providing irrefutable, undeniable evidence of a survival benefit.
And 4S was quickly followed by more compelling studies, wasn't it, building an even stronger case?
Absolutely. The Domasapahas, or West of Scotland Coronary Prevention Study, starting in 1989, demonstrated that pravastatin reduced major coronary events by 31% and all-cause mortality by 22% in healthy men with hypercholesterolemia. So, primary prevention.
Preventing the first event?
Exactly. Then, the CARE, or Cholesterol and Recurrent Events trial, from 1989-1996, showed that pravastatin lowered fatal coronary disease or myocardial infarction by 24%, even in heart attack patients with average cholesterol levels. This showed benefits extended beyond just those with very high levels. These studies built an undeniable, cumulative body of evidence, solidifying statins as a cornerstone of cardiovascular prevention and treatment.
So the question then became, how low can we go with LDL cholesterol? Does lower always mean better, or is there a threshold where the benefits plateau?
That's precisely what led to the establishment of the lower the better principle. Subsequent more versus less statin trials, such as Prove It, TNT, Ideal, and Search, consistently demonstrated that greater reductions in LDL-C, even down to very low levels, led to further proportional reductions in cardiovascular events.
So lower was better.
Lower was better. This effectively dismantled earlier theories about a threshold, beyond which further lowering offered no additional benefit. The evidence pointed towards a continuous benefit, profoundly shifting treatment paradigms and ushering in an era of aggressive LDL lowering for those at risk.
This journey from skepticism to life-saving treatment is truly remarkable. But now, let's take an even deeper dive. We started by hinting that lipids aren't just about your heart. So what does this all mean for us beyond cardiovascular disease? It's painting a picture where the health of your lipids, your emotional state, and your cognitive sharpness are all deeply, undeniably linked.
This is where our deep dive takes a truly fascinating and often overlooked turn. We're moving beyond the well-understood territory of heart health to explore connections that most people, including many medical professionals, might not immediately consider.
Okay, the brain connection.
The core hypothesis guiding this research is that there's a significant association between chronic dysregulation of peripheral lipids, like HDL, LDL, total cholesterol, and triglycerides, and both depression and cognitive decline. Researchers suspected a common underlying biological mechanism,
The shared pathway.
possibly, and a crucial, intriguing aspect of their hypothesis was that depression might not just be a co-occurring symptom, but actually play a mediating role in how lipid levels affect cognition.
So it's not just a direct one-way street from unhealthy cholesterol to a fuzzy brain, but depression might be an unwelcome go-between, almost amplifying the negative effects or disrupting the good ones. That's a subtle but profound distinction.
That's the essence of the hypothesis, and it's what makes this research so compelling. This wasn't a universally accepted idea early on, primarily because previous studies had shown conflicting evidence.
The data was messy.
It was inconsistent. Some analyses, for instance, linked decreased total serum cholesterol or decreased HDL to depression, while others reported no association or even an inverse relationship. The results were all over the place, and sample sizes were often limited, leading to many unanswered questions about the true nature of this complex relationship.
To tackle this critical question, researchers looked at two very different but complementary studies. Let's start with the insights from the familial risk study. This was a truly impressive longitudinal study, meaning it followed people over a very long time, giving a unique perspective on chronic conditions.
Indeed. This was a deeply phenotyped 30-year longitudinal cohort study, started all the way back in 1982, involving 526 individuals. They were carefully categorized by their high or low familial risk for major depressive disorder, or MDD.
So, looking at depression risk specifically,
Exactly. Over these 3 decades, the study meticulously collected psychiatric assessments, information from detailed medical checklists covering 57 different conditions, and, importantly, cognitive testing in a subset of 150 participants during a later phase of the study. This long-term perspective allowed researchers to see how conditions unfolded over an individual's lifetime.
and what did this incredibly long-term view reveal about the links between common medical conditions, depression, and cognitive outcomes?
It showed compellingly that common medical diseases like diabetes, hypertension, and other cardiovascular diseases were significantly associated with both lifetime MDD and eventual cognitive outcomes. More specifically, the researchers created a composite variable they called lipid-associated medical disorders, or LAMD.
LAMD, okay. What's in that?
This variable essentially captured evidence of chronic lipid dysregulation from conditions like diabetes, gallbladder disease, hypertension, and other CVDs. They found that LAMD was significantly associated with lifetime MDD. For instance, in the high-risk group for depression, even after controlling for familial risk, age, and sex, there was a clear statistical link, indicating that these chronic lipid issues increased the likelihood of experiencing depression over time.
That's a strong association, suggesting that our physical metabolic health has a profound impact on our mental health over decades. Did this LAMD also show a link to cognitive performance in this study?
In an exploratory analysis using the subset of 150 participants with cognitive data, LAMD was found to be positively associated with specific verbal cognitive score.
Positively. That sounds counterintuitive.
It was intriguing. Specifically, higher scores on the Walsay similarities, subtest T-scores, and verbal IQ sum of T-scores. Now, this was considered exploratory due to the smaller cognitive sample size, and the relationship might be complex.
Maybe reflecting other factors.
Possibly, or specific types of cognitive function. But it hinted at a potential connection between chronic lipid health and certain aspects of cognitive function that warrants more investigation.
And then there was a survival analysis, which sounds a bit dramatic, but it's about the probability of not developing something, right? In this case, depression.
Exactly. The survival curves in this study provided a powerful visual. They showed that individuals who had experienced LAMD during their lifetime displayed a reduced probability of remaining non-depressed and an enhanced hazard rate, essentially an increased risk over time for developing depression compared to those without lipid disorders.
So having those lipid issues increase the risk of becoming depressed later.
Significantly.
Yeah.
It indicates that having these chronic lipid-associated medical conditions significantly increased an individual's risk of developing depression as they aged. It paints a clear picture of a direct risk gradient for mental health tied to metabolic health.
So the familial risk study gave us this rich longitudinal perspective on how chronic lipid issues contribute to lifetime depression and even hint at cognitive connections. But the second study, the NAS study, was massive and cross-sectional, offering a snapshot of a huge population, correct?
Yes, the NAS study was a highly powered cross-sectional population survey of a very large sample. 2,377 adults with a mean age of 69 from the 2011-2014 cycles. This study utilized the Patient Health Questionnaire 9, or PHQ-9, to assess depressive symptoms.
A standard depression screening
A
tool.
very standard tool. It accurately measured peripheral lipids like HDL and the total cholesterol to HDL ratio, and performed detailed cognitive tests, including the digit symbol substitution test, DSST, the animal fluency test, AFT, and the delayed word recall test, DWRT.
Covering different cognitive areas.
Yes, processing speed, executive function, verbal fluency, memory.
Right.
This robust data set allowed for powerful statistical analysis across a diverse population.
What were the key findings from this large data set regarding the direct relationship between lipids and cognition?
The NAS analysis consistently showed that higher levels of HDL, our good cholesterol, were positively associated with higher cognitive Z-scores across all three cognitive domains tested: attention processing speed, DSST, fluency, AFT, and memory, DWRT.
So higher HDL, better brain function.
That was the strong suggestion. It pointed towards a protective effect of good cholesterol on overall cognitive status in the general population. Conversely, a higher total cholesterol to HDL ratio, which is a known predictor of poor metabolic health and increased cardiovascular risk.
A bad ratio.
Right. That was negatively associated with scores on the digit symbol substitution test, indicating a link to poor cognitive processing speed and attention.
Now, this is where it gets really groundbreaking, tying everything together with the crucial mediation effect involving depression. This is where the unique insight of this deep dive truly comes to light, isn't it?
This was indeed the pivotal finding that brought together these seemingly disparate observations into a coherent, powerful insight. The study revealed that the protective effect of HDL on cognition was absent in individuals who exhibited depressive symptoms.
Absent. Completely gone.
Let me break that down. For cognitive processing speed, measured by the DSST, there was a significant positive relationship between higher HDL levels and cognitive scores in the non-depressed group, meaning more good cholesterol meant better cognitive performance.
Okay, that makes sense.
However, this protective relationship was not observed in the group with depressive symptoms. Their HDL levels didn't seem to correlate with their cognitive scores in the same protective way. It was as if depression had effectively silenced HDL's brain-boosting benefits.
Wow.
Similar patterns were observed for other cognitive tests, like the animal fluency test. The protective link was there for the non-depressed, but vanished for those with depression.
So depression's essentially switched off or blocked the benefits of good cholesterol for the brain. That's a powerful idea.
That's a very apt way to describe it. Formal mediation analysis rigorously confirmed a significant natural indirect effect of depression on all cognitive measures. This suggests that the presence of depressive symptoms mediates, or channels, the interaction between HDL levels and cognitive tests. Meaning, a significant part of HDL's beneficial influence on cognition is disrupted or altered when depression is present. It's not just that people with depression have lower HDL or worse cognition. It's that depression fundamentally interferes with how HDL would normally protect the brain.
That's quite profound.
It is.
Yeah.
This raises an important question. Why would depression mediate, or essentially switch off, the protective effects of HDL on our brain? It suggests a complex, deeply interconnected biological interplay we're only just beginning to understand.
It's like a scientific whodunit, tying together physical and mental health in ways we hadn't fully appreciated.
Yeah.
So if we take both the longitudinal familial risk study and the large cross-sectional NAS study, how do they fit together to give us a more complete, robust picture of this relationship?
They are truly complementary, acting like two different lenses on the same complex phenomenon. The longitudinal familial risk study, with its 3-decade scope, provided invaluable insights into the chronic nature of lipid dysregulation and its strong association with lifetime depression and overall cognitive outcomes. It gave us the timeline, the long view, showing that medical conditions associated with chronic lipid dysregulation significantly increase the risk of developing depression over time. The large, highly powered NAS study, with its robust clinical lipid measures and statistical power, then allowed for the crucial discovery of depression's mediating role in the HDL cognition link in a broad population snapshot. Okay. The consistency of these findings across such diverse samples, with different demographics and study designs, significantly strengthens the validity and generalizability of the overall conclusions, moving beyond mere correlation to suggest powerful causal pathways.
So it's not just a fleeting correlation, it's a profound connection. What are the underlying biological mechanisms that could explain this intricate interplay? And what are the big clinical implications for us, the listeners?
From a mechanistic perspective, the connections are likely multifaceted. Lipid dyshomeostasis can affect cognition through direct biological pathways within the brain itself, altering things like synaptic transmission and neuroplasticity.
Brain cell communication and flexibility.
Exactly. Crucial for learning and memory. But it also seems to act indirectly through psychological factors, most notably depression. Depression, as we know, is already a major risk factor for neurocognitive decline. These findings suggest it might act as an amplifier, aggravating cognitive decline or significantly reducing the benefits of protective lipoproteins like HDL.
It's almost like depression creates a hostile environment where even good things for the brain, like HDL, can't do their job effectively. That's a sobering thought.
Precisely. And the influence might even be bidirectional, creating a vicious cycle. Alterations in lipid metabolism could also be a consequence of depressive symptoms.
How so?
Well, patients experiencing depression are often more likely to engage in unhealthy behaviors, such as physical inactivity and poor nutrition, which can directly lead to dyslipidemia and metabolic syndrome.
Makes sense. Harder to exercise or cook healthy when depressed?
Right. Furthermore, the chronic stress and mental illness-related distress associated with depression can cause biological neurocognitive decline through vascular changes in the brain and excessive release of stress hormones like corticosteroids, both of which can damage brain areas critical for memory and learning.
That's a powerful and alarming feedback loop. What does this mean for early detection and potential interventions in a clinical setting? Could we actually use this information?
These findings highlight the significant potential for medical conditions characterized by chronic lipid dyshomeostasis to serve as early predictors for the risk of both depression and subsequent cognitive decline. This is a critical clinical promise.
Using lipid problems as a warning sign for brain health issues down the line.
Potentially, yes. The mediating impact of depression suggests that earlier detection and targeted interventions for both mental health status and peripheral lipid dyshomeostasis, both of which are treatable with medication and lifestyle changes, may ultimately have a profound and positive impact on cognitive outcomes. This could lead to a more holistic, integrated approach to brain health, moving away from treating these conditions in isolation.
Treating the whole person, essentially.
That's the goal.
And are these findings connected to larger neurodegenerative issues we're already grappling with, like Alzheimer's?
Absolutely.
Hmm.
Lipid dysregulation is a well-established underlying mechanism for vascular dementia and is increasingly linked to Alzheimer's disease. This study directly connects with recent groundbreaking work showing that the APOE4 genetic risk factor for late-onset Alzheimer's.
The main genetic risk factor.
Yes. It's fundamentally involved in cholesterol trafficking, and research shows it actually alters brain cholesterol levels and underlies some of the cognitive deficits associated with the disease. So we're building a more complete picture of how fundamental metabolic processes, especially those related to lipids, contribute to complex neurological and neurodegenerative conditions. It shows just how intertwined our body systems truly are.
So what does this all mean for us? It's painting a picture where the health of your lipids, your emotional state, and your cognitive sharpness are all deeply, undeniably linked.
It's a powerful call for a paradigm shift, really. We can no longer afford to view these systems in isolation. Our mental and physical health are inseparable.
The day we embarked on a deep dive that truly transformed our understanding of lipids. We started with their foundational role in cardiovascular disease, then traversed the captivating and at times incredibly contentious history of cholesterol research, uncovering how scientific perseverance eventually prevailed over decades of skepticism.
From there, we ventured into the surprising and profound connections between dyslipidemia, depression, and cognitive function. We saw how chronic lipid dysregulation can predict depression, and crucially, how even the protective effect of good cholesterol in the brain can be dramatically impacted or mediated by the silent, insidious presence of depressive symptoms.
This research underscores a powerful truth. Our physical and mental health are not separate entities, but an intricately woven tapestry. The health of your lipids isn't just about your heart. It's about your mood, your memory, and your overall cognitive vitality. It's truly a holistic system where the well-being of one part deeply influences all others.
Given that early detection of both lipid dyshomeostasis and mental health conditions are pharmacologically tractable, meaning we have effective treatments for them, this raises an important question. Could integrating mental health screenings into routine lipid checks become a standard practice?
Screening for depression when you check cholesterol.
Not just for mood itself, but perhaps as a critical proactive step to preserve our cognitive future, given this mediating role we've discussed.
And on a personal level, how might you reevaluate your holistic health strategies? Understanding that nurturing one aspect, be it a heart-healthy diet, consistent physical activity, or dedicated mental well-being practices, could have profound ripple effects across your entire system, from your arteries to your ability to think clearly and maintain a healthy, resilient mood. It's certainly something worth pondering and perhaps acting upon.
A profound thought indeed, offering new avenues for optimizing our overall well-being.
Stay curious, keep learning, and continue your own deep dive into what keeps you thriving.